Get started. What we see here in the New England Journal published this week is a scalp of a patient. He's 37 years old. He's had a 4-year history of excessive sweating, headaches, and joint pain. His wife thinks he looks rather peculiar. He actually looks like he's been wearing a chicken wire helmet. And we're given a differential diagnosis that includes acromegaly, amyloidosis, systemic sclerosis, hypogonadism, and sarcoidosis. I don't think this is sarcoidosis. We're not given the opportunity to see his gonads, so I can't comment on that. Systemic sclerosis certainly involves the skin, but mostly the skin of the extremities and the face, and this is the scalp. Amyloidosis involves also the skin and subcutaneous tissues. I've never seen amyloidosis of the scalp, so we're left with acromegaly, which certainly causes dramatic skin changes, although I've never seen anything quite like this. But this is with acromegaly. The authors were very careful not to show us his face. I assume that we'll see his face in the next issue of the New England Journal, because usually the facial structure, dermal bone, is particularly affected, including the bones of the face and the jaw, etc. And the skin becomes thickened because of an increase in connective tissue, etc. So we'll learn more about this patient's problems next week. In the New England Journal, there's a report on the problems that have occurred very recently regarding angiotensin receptor blocker recalls. Now, what generally happens is once the big drug companies that usually buy these products from someone else are confronted with their patents no longer making these products into so-called blockbusters, they then sell these rights to other companies. And they may be located in various places. So there's been a scandal regarding impurities that primarily involve 2 factories, one located in China and one located in India. And the contaminating products involve nitrosodimethylamine and various nitric amines that could possibly result in cancer. Now, are the patients that are taking these products going to get cancer? Well, the FDA has looked into this, and you would probably have to ingest a tablet of this every day for 70 years, which would increase your risk of cancer from an ostensible value of 0 to 1 in 100,000. So this risk is not great, but nevertheless, this is a big scandal, and it's certainly made the press in all countries, including Europe. No one knows exactly what to do about this, although companies are required to maintain certain purity standards. And the products involved here include valsartan, which was previously marketed by Novartis, losartan, and other AT1 receptor blockers, including irbesartan. So I don't know exactly what's going to happen to this, but what's surprising is that just because the product is labeled as belonging to one specific company doesn't mean that that company provides the product, because apparently often a few manufacturers are responsible for supplying all the companies that use them, and these manufacturers then perform repackaging. I think we would otherwise call this mislabeling of these products, implying that it comes from them instead of from some place nobody's ever heard of in India or China. This is a scandal, and it's embarrassing. Next case. The first topic of the New England Journal involves progressive multifocal leukoencephalopathy. This is a neurodegenerative disease of white matter that is almost invariably fatal. And it's a viral disease that comes to be through a polyoma virus named after a patient whose initials happen to be JC. So this virus is called JC virus. JC virus can also cause a renal disease in patients that have undergone renal transplantation, but that's usually not much of a clinical problem. However, progressive multifocal leukoencephalopathy is a severe problem that occurs in AIDS patients, in patients with underlying hematological malignancies, and in patients with multiple sclerosis that are treated with antibodies against a surface adhesion molecule called VLA4. Now, there is no treatment for this condition, so investigators thought, well, if we can get T cells to attack cancer cells and that we suppress a controlling mechanism involving the programmed death molecule 1, perhaps we can get these T cells then to also go after JC virus, which they generally do in people that are healthy. So it was decided to treat these patients with this multifocal leukoencephalopathy with pembrolizumab, which blocks this programmed cell death receptor. So that was done in 8 patients, and these patients have various underlying conditions, chronic lymphocytic leukemia running through all sorts of treatments, and here's a patient with HIV, and here's another patient with a non-Hodgkin's lymphoma, and here's a patient with idiopathic lymphocytopenia. Don't know exactly what this patient has, but at any rate, severe immunosuppression. Here's a patient with another condition requiring immunosuppression. Here's another patient with Hodgkin's lymphoma. Here's another HIV patient. And all these patients had progressive multifocal leukoencephalopathy. All of the patients were treated with this antibody against PD-1 ligand. And here is that 4 of the patients got quite a bit better. 1 of the patients probably got better, and 3 of the other patients didn't get very much better. So there was better than a 50% response in a disease where we would expect all the patients to die. And in the supplement, there were MRI findings supporting the author's contentions that these patients got somewhat better when they were treated with this strategy. So the patients were treated from 4 to 6 weeks with pembrolizumab, and 5 of them looked like they got some better. 4 of them probably did indeed get better, and the major side effect was 1 patient had recurrence of psoriasis, and another patient had a nonspecific skin rash. Now, the next topic in the New England Journal involves the transplantation of organs from patients that are hepatitis C infected. And previously, all these organs were thrown away. But since organ supply is limited, since many donors are drug addicts that die from overdoses, and since these drug addicts are commonly hepatitis C virus positive for various reasons, and since we also now have effective treatments against hepatitis C virus, a study was done to address this issue. This is not a randomized controlled trial, but the appearance of organs from hepatitis C virus positive and negative patients is relatively common, so that the 2 groups could be compared. And in the patients that were hepatitis C virus positive, the recipients were then immediately treated with anti-hepatitis C viral treatment in an aggressive manner. And so what we see here is the number of organs from hepatitis C virus positive patients were 44 organs. And if we look to see at the donors in general, it's amazing the number of donors that are there because of illicit drug use months prior to death. And more than half the patients from this group of donors was hepatitis C virus positive. So that's where the donors come from. And it would be a pity to throw functional organs away if we have a treatable condition. Now again, this was not a randomized controlled trial. So these are all the patients followed from hepatitis C virus positive donors. And the recipients all got hepatitis C virus because the organs they received were filled with hepatitis C virus. Only 1 of the recipients has died thus far of conditions that were not related to hepatitis C virus, and the rest of the patients did fairly well. The green patients down here haven't been followed up long enough to be actually included in this analysis, but they're shown just the same. So only one patient has died, and his death had nothing to do with hepatitis C virus. And what we can see here is that the hepatitis C viral RNA load in the recipients that obviously all became infected nevertheless dropped to 0 in every patient within 2.5 weeks after transplantation. And what we can see here is that the donor hepatitis C viral NRA copies was closely associated with what the recipients then received, as one would expect. So the data suggest actually that the patients that were transplanted from hepatitis C viral positive donors actually did a little bit better than the patients that received organs from hepatitis C virus negative donors. And the authors suggest that these patients that are hepatitis C virus positive, that their organs shouldn't be thrown away and that they should be utilized for transplantation, provided that an aggressive treatment against hepatitis C virus is given to the recipients after transplantation. The next topic at the New England Journal involves ventricular assist devices, and there are two major products on the market. Both are driven by magnetic dependent pumps, and one of them involves a centrifugal pump, that's shown here, and the other involves an Archimedes screw-like pump, an axial-flow pump, shown here. And a randomized trial comparing these two forms of ventricular assist devices has previously been published in the New England Journal, suggesting that the centrifugal pumps function better than the axial pumps. This issue is important because, as we know, large numbers of patients with terminal heart failure are now treated with these pumps, and the tolerance to these pumps seems to be improving as we move along. So there's 500 patients in each group. One of them got the centrifugal flow pump and the other one got the axial flow pump, and now they've been followed for longer periods of time. And what we can see here is that the centrifugal flow pump does better than the axial flow pump, although both, in my view, do pretty well, but there's a 15% difference between these two groups. And if we look at first of all, centrifugal flow is certainly not inferior to axial flow, probably the other way around. If we look at these data, the centrifugal pump is a little bit newer than the axial flow pump, but what we see is that thrombosis resulting in pump replacement was much less present in patients that got the centrifugal flow pump, and things like strokes and other things that we don't want the patients to have were also significantly less in the patients that got the centrifugal flow pump. So in summary, this is the final analysis. The authors promise that we don't have to deal with this topic again. Centrifugal flow seems to beat axial flow. So the new pump seems better than the old pump in terms of complications, particularly disabling stroke or requiring a reoperation to replace or remove a malfunctioning device. The next topic at the New England Journal is a hematological malignancy. I confess I've never heard of this disease. It's called blastic plasmacytoid dendritic cell neoplasm. And it turns out that this is responsible for 0.44% of all hematologic malignancies, which are probably responsible for about half of all cancers anyway. So this is a major health problem. Nevertheless, it's interesting because it involves dendritic cells that would have certainly interested Paul Langerhans, who was the first to describe these cells. And so we could imagine that this malignant disease of dendritic cells probably causes skin problems, which it certainly does. Now, to understand the subsequent report, we also have to understand how diphtheria toxin works. Thank God we don't see this disease anymore, since we've got, first of all, a passive neutralizing antibody against the diphtheria toxin, and we have active vaccinations to keep people from getting diphtheria. But diphtheria usually caused pharyngitis with the development of this necrotic material in the posterior pharynx, and these Corynebacteria release a toxin. This toxin binds onto cells, is incorporated into cells, and interferes with a transcription factor called the elongation factor, number 2. And if the elongation factor number 2 is blocked, then these cells are driven into apoptosis and die. That's how diphtheria toxin used to kill people, through this mechanism involving the elongation factor 2. Now, wouldn't it be clever if we could develop a therapy involving diphtheria toxin, but we could steer this therapy only to specific cells that we wanted to die? And that's the strategy that was used against this cancer. So tigraxofusp is a fusion protein that consists of a binding partner to IL-3, and it's coupled to diphtheria toxin. So cells that express a whole bunch of IL-3 receptor are subject to being invaded by diphtheria toxin, interfering with their elongation factor 2 transcription factor, driving these cells into apoptosis. And that's what was done here. So tigraxofusp was used to treat blastic plasmacytoid dendritic cell neoplasm, because these cells happen to express a whole bunch of human interleukin-3 receptor more than other cells, making them particularly susceptible to this treatment. Now again, this is not a randomized trial, but 47 patients with this obscure hematologic malignancy were treated with tigraxofusp, and we'll see what happened to them. So no previous treatment, 32 patients, 15 patients had already been treated by something else. There are 47 patients in this study, and it involves their bone marrow, their skin, their lymph nodes, and etc., as shown in this little table here. Now, the outcomes look pretty good, because what we see here is that some of the patients also receive other treatments, stem cell transplantation and what have you, but the Kaplan-Meier analysis of overall survival, nobody died after 18 months. They're all still here at the end of 42 months. And here's some examples. There are other examples shown in the supplement, but this woman with this terrible skin condition related to these dendritic cells, I'm sure she felt a lot better after this treatment. So one of the, no treatment is without complications, particularly something of this nature. So there are other cells that obviously express IL-3. So one of the important side effects in this study was the capillary leak syndrome, which afflicts numerous patients in intensive care units, but also patients that are with malignant disease that are treated with various therapies, including this one. So this is clearly an adverse effect, and we can look at these various other complications that these patients had. This is not a trivial therapy. After all, diphtheria wasn't harmless, but with this novel treatment, this very directed treatment against this malignant disease seemed to be successful. So I think we'll probably be hearing from tigraxofusp or other similar kinds of agents to treat other conditions in the future. The review in the New England Journal involves hazard chemical emergencies and poisonings. And this is something that every clinician should know something about. And clinicians should be able to recognize toxic syndromes and at least categorize them into boxes so that sensible things are done with these patients. And this is a pretty good review on this topic. And there are two poisonings that every clinician should know something about, because they involve patients that are exposed to environmental disasters like fires, for instance, firefighters that come into emergency rooms. And the major issues here in firefighters that have ingested smoke inhalation and similar things are carbon monoxide poisoning, cyanide poisoning, and also organophosphate poisonings have to be considered, particularly in people that work in agricultural settings where insecticides and similar toxins are used. And so this is just a representative list of hazardous chemicals. And in English, they're divided into respiratory irritants. That involves sulfur dioxide and chlorine gas. These were also used in World War I. For instance, phosgene was a popular agent, and people that breathe this stuff develop immediate respiratory distress. Another class of agents that was used in World War I are vesicants. These are blistering gases that result in blisters on the skin and inside the mouth and respiratory tract, like nitrogen mustard. And then there are cholinergic agents, which thus far to my knowledge have not been used in warfare except in recent times, in the Middle East, for instance. And these involve organophosphates that are used also as insecticides and to deal with other organisms that are susceptible to them. Now, these are potentially military nerve agents, although they've not been applied on a large scale. And we have to, as clinicians, think about what are these agents going to cause in a group of patients, particularly if 100 of them show up at once. Who has hypoxemia? Who is in essence hypoxemic but has normal blood gases? How do we separate these patients into various groups so that we can apply relevant treatment? And so the asphyxiants, okay, they should have a low PO2 in their blood gas analyzer, but then there are some problems that could confuse us. Agents that cause methemoglobinemia, carbon monoxide, cyanide poisoning, and hydrogen sulfide poisoning. In oximetry, to look at oxygen saturation, that's not going to be helpful. And the blood gas analyzer that we have to have here is a modern co-oximeter device that gives us also levels of carboxyhemoglobin and answers of this nature. Otherwise, we'll be faced with patients that don't have oxygen available for their cells, but nevertheless have normal arterial oxygen pressure and saturation. This is a problem in dividing these syndromes into how to treat these patients, particularly if the physician has to wear this kind of contraption even to touch these people or to draw their blood specimens, etc. Because we don't want the healthcare personnel to develop conditions that are more toxic than what the patients have. And with some of these agents, spread of these agents by contact through these patients is certainly possible. Now, there are general agents that are used to try to facilitate airway problems from toxic inhalant injuries. And these are present in every emergency room or an emergency kit that physicians have that arrive on the scene. Albuterol, continuous nebulization, corticosteroids, prednisone, methylprednisolone. These are first aid agents, but they obviously don't deal with the underlying conditions. Cyanide poisoning. Cyanide binds to F2 plus iron. So it's going to involve hemoglobin, yes, but more importantly, it's going to involve the enzymes that are involved in mitochondrial oxidation. And blockade of these enzymes is going to result in asphyxiation, irrespective of what the person's PO2 is. So we have to somehow be able to recognize cyanide poisoning when it occurs and to develop a strategy on what to do with it. Tachypnea, tachycardia, nausea, okay. Pupils should be dilated. What we might observe is that the people are not able to conduct a sensible metabolism of oxygen. That means that the PO2 in their venous blood that returns to the heart is hardly lower than the arterial blood that delivers oxygen to the systemic circulation. We would probably expect metabolic acidosis from lactate accumulation, etc. And then the question is what to do about this. And cyanide is metabolized through an enzyme called rhodonase. Rhodonase activity can be increased if we if we deliver sulfur-containing compounds. So giving sodium thiosulfate is one of the classical strategies to deal with cyanide poisoning. Another strategy is to change as much iron +2 into iron +3, and this can be accomplished with various agents, including 4-dimethylaminophenol. So having these around in an emergency room is probably a good idea, but the best treatment for this condition is the administration of hydroxycobalamin.
You too.
And hydroxycobalamin binds cyanide, converting it to a product that's then excreted in the urine because cyanide binds to cobalt. And so these materials should probably be present in a modern emergency room setting. And that's how they're given. The other problem that might confront us is organophosphate poisoning, nerve gas. Now, these patients are obviously also in some sort of distress, but what happens here is the organophosphates bind to cholinesterase. Acetylcholinesterase is necessary to dispose of acetylcholine that's elaborated by nerve endings, and if that doesn't happen, the subsequent nerve ending is continually depolarized. It means that all skeletal muscle is immediately depolarized. The people jerk just once, and anything controlling some sort of an exocrine gland is stimulated continually. So these, all the tears, sweat, everything that produces slime, etc., and mechanisms that constrict the pupils are all turned on. And our problem is how can we reestablish acetylcholinesterase? Now, one of the agents that's involved in this, here's the structure of organophosphates. They've been known for 60 years, and this is Novichok. Now, the next time you're in Bangkok airport, it's probably unlikely that the person next to you is going to collapse because of Novichok. But this is also known. And what we have to do here is to recognize this condition and to try to reestablish acetylcholine activity. And what we can do is we can give atropine, and the right dose of atropine here is enough. And what's done in these patients is they're infused with atropine, and you monitor the pupil to see if you can get the pupil to dilate, and the right dose of atropine is enough. These are much greater doses than we give to a bradycardia country. And the other material that's used is pralidoxine to try to reestablish acetylcholinesterase activity. So much for that. There was a picture in the New England Journal last week involving this poor woman with hydroxychloroquine toxicity. She has bilateral, probably permanent areas in her macular vision in her retina that have been destroyed through hydroxychloroquine that interferes with metabolism in the retina so that autophagy no longer occurs properly. Now, the next case in the New England Journal also involves a patient with hydroxychloroquine toxicity who had problems with her vision, as shown on the left. And what we can see here is with optical coherence tomography, this is not shown in color, she has changes in her retina in the macular area consistent with chloroquine toxicity, although her fundoscopic examination in this example was normal. But this doctor sent this patient to a yearly evaluation by an ophthalmologist to make this diagnosis in time so that her vision was spared. Then you'll recall that last week I grappled with this case, which I thought was rather frustrating. This is the 54-year-old man with alcohol withdrawal. He drinks a gallon of vodka a day. Since that's almost 4 liters, I thought that might be close to an indoor track record. But at any rate, he develops alcohol withdrawal syndrome, might imagine. The doctors treat him with lorazepam He also gets phenobarbital. I think these treatments are all okay. And he's given thiamine and vitamins, etc. Now, on the evening before he's be sent to some sort of home, he develops a second syndrome, which also involves coma and signs of gastritis, because he develops nausea and vomiting. He develops an ileus, and the CT is done showing all the small bowel gas. Clever surgical resident puts a nasogastric suction tube in, and a bunch of hematest positive black material comes out, so he has gastritis. And nobody knows exactly why he's developed coma. And I didn't really like this either. I suspected that he might possibly have isopropyl alcohol intoxication, but his ketones in the urine were only mildly positive, which they'd also been at other episodes within this hospitalization, as they are in people that don't get enough calories, etc. And isopropyl alcohol is metabolized directly to acetone. It doesn't cause acidosis, but it should cause marked ketosis. And I couldn't find evidence that this patient really had marked ketosis. A neurologist comes along. I don't know why, but the neurologist does an electroencephalogram. He finds that it's slowed, which it generally is in patients with coma, but the time frame in which the neurologist was there was certainly longer than 2 hours, so I would expect this patient to have a marked degree of ketosis, which apparently didn't have. So a various differential diagnosis is considered by this discussant, and he observes that laboratory tests are done, and this patient's isopropyl level by that time was 0, probably because he's got his alcohol dehydrogenase is so well trained with the 4 liters of vodka per day that he catabolized all of that to acetone. But his acetone level was elevated, which I would think would cause a marked increase in his ketone levels. I learned to my interest that in Boston, apparently, the hand sanitizers that are used, they should contain chlorhexidine, the way they do it in Europe, but they contain a solution that consists of 63% isopropyl alcohol. And he probably drank a container of this stuff to develop this syndrome, because isopropanol, as shown here, is metabolized to acetone. Here are some other examples of alcohols that are also metabolized to products that necessarily do not cause metabolic acidosis. So that was that patient. So we learned something about how hand washing is done in Boston. Now, 50 years ago, we wouldn't have had this problem because we couldn't measure isopropyl alcohol and we couldn't measure acetone either, but we had these wonderful tablets that were present on every ward where you could just use the tablets and put a little bit of serum on each tablet to see how much acetone is present in the person's blood. This is an intercruside reaction, and so we would have had this diagnosis in much less time 50 years ago. Also in the New England Journal, I learned about this new delivery system for people that don't like to get stuck. And most patients would much rather take a tablet than get an injection. For instance, with the new glutid products that are present to treat type 2 diabetes. Well, with this new product here, you can just swallow the thing and it gives you an injection inside the gastric mucosa, which apparently the patients don't perceive. Thought that was interesting. Next, we move to the Lancet. And the first paper in the Lancet involves comparing a so-called biosimilar to infliximab. You'll remember that infliximab is an TNF antibody that's used in patients that have Crohn's disease and other conditions, neurologic conditions in general. So these patients get either infliximab or CTP13. And the hypothesis here is that CTP13 is no worse than infliximab in these patients with Crohn's disease. So here are the patients, and there are over 100 in each group, and there are various ethnicities, and their Crohn's disease is fairly well established, but they need this biological disease modifier to remain in remission. So these two treatments are compared. These studies are not thrilling, but I suppose they have to be done. So we learned that CTP13 is not inferior to infliximab. Let's just hope it's cheaper. The next study in patients with young patients, children with ulcerative colitis. And the idea is to try to treat them with a regimen so that they're steroid-free at the end of a year. And in this study, stool samples and biopsies were obtained that were looked at in terms of microbiome and other surface markers that might be termed biomarkers, so that a precision medicine would sometime be possible in the future. That's how this paper made the Lancet. So it's not a randomized trial. 467 patients with ulcerative colitis were enrolled here, and they were scored in terms of various gastroenterological procedures, and one decided that some of the patients had mild disease and others had moderate disease. And since persons with moderate disease are sicker than the ones that have mild disease, all of these variables that were looked at here were statistically significant. I would certainly hope so. And if we look at the patients at the end of the year, the patient that had mild disease in terms of their corticosteroid-free remission intervals did better than the patients that were sick. And in terms of incidence of escalation of anti-TNF alpha therapy, the patients that were sick required more treatment than the patients with mild disease. Generally, we would call this a no-brainer, but that's what happened. Then the authors looked at these wonderful biomarkers, comparing these rock curves. And the clinical criteria, looking at the patients, whether or not they're sick, and the kinds of scales that every clinician utilizes, is shown in the red line. And adding these new super biomarkers, we see this shaggy blue line. Now, the authors were very excited about these findings. I found them not particularly impressive. So you can look at that. In the next paper, we look at treatment for people that fall asleep during the daytime because they're obese. And these patients with so-called sleep apnea syndrome or obesity-associated hypoventilation are generally treated with continuous positive pressure airway, CPAP, if they're willing to comply with this treatment. So if you put them to bed at night, you put them on a CPAP machine, and the CPAP machine is supposed to provide positive end expiratory pressure to keep their airways open all the time. Now, CPAP is sort of a brainstem treatment, and the patients aren't crazy about it, but it does seem to help the patients make them better. Now, here's another form. CPAP is non-invasive, so the patients don't have to be intubated. But there's another form of non-invasive ventilation that's called non-invasive ventilation, and it also involves positive airway pressure, and the patients don't have to be intubated. And the only difference between this lady and the previous picture is that this lady's awake, and the drawing of the previous person, the person was asleep. Now here, the amount of resistance, the positive pressure that's administered to the patient is different during inspiration compared to expiration. And the idea is that this treatment is more comfortable for the patients, I assume. I'm not an expert on this, so this form of non-invasive ventilation was compared to CPAP in this large trial in patients with obesity hypoventilation syndrome. I thought they should have had a third group that had gastric bypass, but that wasn't done. So if we look at these patients, their BMIs are greater than 40, their neck circumference is certainly greater than 40 centimeters, 45 centimeters in both groups, and they both have a problem that would ordinarily be treated with CPAP. So they were randomized to this more expensive form of non-invasive ventilation compared to CPAP. So the idea here again is that the more expensive treatment is no worse than CPAP, and it wasn't. So the probability of survival in both groups was the same, and the cardiovascular events and overall mortality were the same. And it looks like the patients with the more modern treatment actually had a little more decrease in systolic blood pressure than the patients on CPAP. I'm not sure why that is. There was no difference in diastolic blood pressure. If we look at their PCO2s, they went down in both groups, and that's what we would like to see. Their pH values went up a little bit, and we would like to also see that. Their serum bicarbonate levels fell from 30 to 27. That's pretty good. And their PO2s, so their saturation was 90% here, and it increased to about 96% here, and that increase was, I don't see any clinical difference, irrespective of what the adjusted p-values are. Now, since the modern form of non-invasive ventilation is so much more expensive, the authors had to admit that given that continuous positive pressure airway is cheaper and easier to implement than non-invasive ventilation, both forms are non-invasive, the authors concluded that CPAP is probably better in terms of the first line intervention. The next topic in the Lancet involves the area of Swat in Pakistan. And it's pretty close to the Khyber Pass, if you remember your Rudyard Kipling stories. And as we can see here, in terms of nature, it looks wonderful. But there are a lot of problems in this area of the world. And you'll recall that several years ago, a 14-year-old girl by the name of Malala Yousafzai was shot by the Taliban and didn't die. And this story made the press. And so this area in Pakistan, Swat, is termed a post-conflict setting. Wasn't so clear to me that the area is now post-conflict, but I think that post-conflict setting in terms of Lancet English is synonymous with war zone. And so what they did here is they randomized these poor women living in this war zone to two groups, and one group got a psychotherapy and the other group did not. And if we look here, is that they number of participants, almost 1,000 in each group, and those, so in the randomization scheme, there was 654 in one group and 659 in the other, and over the period of observation, half of the patients disappeared. I think that that's a bad sign in terms of clinical studies. But at any rate, if we look at these patients in this war zone, more than 80% in both groups had never been to school at all, which means that they're illiterate. Now, their occupations are listed as housewives, whatever that may be in Swat, but at any rate, half of them lived with a husband, and the other half lived with husband and mother-in-law. I could imagine that there's a lot of stress here, and they by being in their early 30s, both groups already have had 5 children. So no education and 5 children. So what came out? Well, the authors decided that the psychotherapy in the patients that were left over in this study was better than doing nothing. I believe them, but perhaps they should have sent the control group to school to see if maybe that would be better than psychotherapy. But that wasn't the author's intention. So this is terribly unfortunate and sad, but that's life in Swat in Pakistan. The review in the Lancet is osteoarthritis, which afflicts probably all older persons. How to deal with this is not always clear. Probably avoidance isn't bad. Not being obese, staying active, keeping your cartilage alive through activity, etc. The global messages are the presence is increasing. I think we know that. It's prevalent in high-income populations, but it's prevalent in all populations. We don't necessarily have to send the people to magnetic resonance imaging. We can look at their fingers and look at them clinically. Key treatments are education, exercise, and weight loss. Okay, those are good ideas, I suppose. Good luck. Disease-modifying treatments, always a good idea. Inappropriate treatments, including arthroscopy and opioids, should be actively discouraged. I like that. And you can look at this in yourselves. So the distribution of this condition, obviously it's increasing as the population gets older. The condition is actually more prevalent in older women than in older men, perhaps because the older men have already died. I'm not certain, but I think that this condition is probably more common in women and men. And okay. The difference seems to begin already in middle age, progresses over time. And the molecular mechanisms have been looked at in great detail and perhaps offer some sign of intervention, although for this condition that's not yet clear. And what can we do about this? Pain behavior, psychosocial, okay, socioeconomic, like that. Probably have to keep the people somehow on their feet, keep them moving. And the clinical crepitus, restricted range of motion, bone enlargement, you can look at the fingers to figure that out. The inflammation here is relatively modest, and that this condition involves Wnt signaling pathway and beta-catenin, what doesn't? And that agents that are involved in bone reconstruction and in phosphate metabolism, PTH and MAPA and anti-L1, interleukin-1, etc., inflammasome, all of this fits. The next review in the Lancet, I really like this one, is the management of opioid use disorder in the United States. And the authors conclude, I love this, there is an urgent need for expanding the use of medications for opioid use disorder. Sounds reasonable. Then they talk about withdrawal from opioids. I'm told that this can be lethal, although I think the evidence for that is relatively scant, but okay, it's a clinical problem. The hazardous pattern of opioid use. I hate flanking nouns with two prepositions, but whatever. And opioid dependence, we've talked about this in detail. I was interested in this table because I think this shows a large crux of the problem here. Dispensed by physicians, dispensed by physicians, dispensed by physicians, dispensed by physicians, dispensed by... Could doctors be at fault here in some way? The answer is, it might occur to me. And who are the risk factors of getting opioid use disorders? More common in men than women, although women certainly are subject to this too. Getting a lot of opioid prescriptions is worse than just getting a little. Alcohol and benzodiazepines and other drugs, I think we knew all this already. And what can be applied here? Pretty complicated, but I'll let you look at this. I was interested in this feature in the New England Journal. And you can click this on also because this is a new adaptive learning module on how to prescribe pain medicines. And the New England Journal offers this free of charge, so you don't have to pay for this. And I'm going to show you some of these questions. There were 60 questions that I had to deal with here. And as I went over this, I felt like Rip Van Winkle. And Rip Van Winkle is the first short story that was published in the United States by Washington Irving. And Rip Van Winkle is a young man, Dutch extraction, who ends up in this valley in upstate New York called Sleepy Hollow, and he goes to sleep and he wakes up 20 years later, has this white beard, and the world has changed. And he's discovered that King George isn't king anymore, and George Washington is already retired. He also finds out that his wife, who tortured him all his life, has died. So there are upsides to this. But when I go to the United States and I look to see what's happened in the last 30 years, I feel like Rip Van Winkle. So I'm going to show you these questions because the Americans are concerned because of 130 overdose deaths every day. And the prescriptions for opioid analgesics is a major contributor. So we'll look at these patients, the questions that I had to answer. And the first one, it's a 47-year-old man with hypertension. And he's been drinking a lot, and long story, short answer, he has laryngeal cancer. Now, this poor patient has spread of his disease to the point where he has a gastrostomy tube. And so he obviously has malignant disease with metastases. And if he's now got a gastrostomy because of head and neck cancer, the chances that he's going to be around next year are fairly modest. So how can we treat this patient that can no longer really swallow his tablets? And I thought that a transdermal fentanyl patch would be a good idea for this patient, and I got an answer right. Now here's the next question. A 55-year-old man, this is amazing, he's had chronic low back pain. He's been to operations 3 times. He's had failed laminectomies for unclear reasons. Apparently, herniated disc wasn't part of the problem because all the laminectomies failed. And he receives methadone, 5 milligrams every 8 hours, continually. So in essence, he's already a methadone addict. Now, what happens then is he slips on the ice and he develops a non-displaced left humeral fracture of the humeral head. And orthopedists are fairly conservative about this, and you can treat 80% of these patients with merely a sling, and it gets better. And after a week, they can start doing some PT and moving this, and it gets better. But now the patient, according to the smiley face scale, has an additional pain. I mean, he's already a methadone addict, and then now he has a pain, and he calls himself a 9 out of 10. What to do? Well, I thought, I'd probably call up the surgeon and say, hey, this guy is having substantial pain. Is this usually what happens here? Because sometimes these things can get dislocated, or perhaps the small artery that supplies the humeral head has somehow been damaged, and maybe additional imaging, or 20% of these patients have to be operated upon. But that wasn't an option. So I had to pick how to give him more opioids and how much. That was in essence the right answer. And I picked give him, in addition to the methadone that he's already getting, oxycodone 5 milligrams every 12 hours, because that was the lowest possible dose. But no, the right answer is to give oxycodone every 4 hours. I was interested in that. Here's another one. This woman's had a bilateral mastectomy for breast cancer, but the breast cancer was only present in one breast, and they didn't say that she had BRCA1 or BRCA2, or BCRA1 or BCRA2, so I don't know why both breasts were removed. And there are more conservative operations, and so she comes in tearful and complains of pain. What to do? Well, I thought she might be depressed, and because she certainly has reason to be depressed, and that answer was correct, so I was happy about that. Then here's a 45-year-old woman who works as a nanny, okay? She has chronic severe scoliosis, okay? That can result in back pain, but she's had it all her life. She gets oxycodone every 12 hours. And her urine is tested for drugs because apparently now the patients sign some sort of contract with they don't call them doctors anymore. These are primary pill providers. So she has a contract with that and gets her urine tested, and then she has some additional, what happened to her now? ERLA is extended release long-acting oxycodone, 15 milligrams every 12 hours. So her product has changed to that. And then there's a question is, should she be driving a car? Well, I don't know. Should all these people getting all these drugs be driving in the first place? And so the question was, what should I tell her about driving a car? Well, I'd take the bus was not an option. So I picked refrain from driving for at least 1 month. But apparently, you only have to tell them to refrain from driving for at least 1 week. Missed that one. And so here's the next one. Here's another patient. 67-year-old woman has hypertension and low back pain. And she reports that her nephew recently died of an opioid overdose. And she's getting long-acting morphine sulfate, 60 milligrams twice daily. We used to give 8 milligrams to treat acute pulmonary edema, but she's getting 120 milligrams of morphine a day. So, and she's worried that she might become an addict. I guess she's right. She might become an addict. And so she's also signed one of these patient provider, pill provider agreements, and you review all her stuff here, and it turns out that she has naloxone at home, good idea, and her spouse has been trained in using it. And then the question was, what's the risk that her nephew, he's already died, so that's not the problem. So I picked this answer, discuss a dose reduction of her opioid pain medications. Always think that's a good idea. So here's the last one. Which of the following next steps in care is most appropriate for a 40-year-old woman who's been taking oxycodone 20 milligrams twice daily for 4 years for neck pain? I mean, this woman is 40 years old. She might live another 40 years. 60 milligrams of morphine for neck pain? Okay, and then there's maintain the current oxycodone dose and add a laxative. Probably needs one. Increase the dose of oxycodone. Switch to an alternative opioid medication. I give up. So I had to, you can pick the, I don't know, think so, unsure, no idea. I wasn't very confident, but I got it right. Switch to an alternative opioid medication. Discontinuing opioids wasn't an option. That, ladies and gentlemen, is it for this week. And if you'd like to practice your German, we'll move on in the next 4 minutes and you can hear it all again. Thank you for listening. Das ist doch erstaunlich.